It is my great pleasure and honor to introduce Dr. Lionel, consultant in clinical transplantation, Toulouse University Hospital, Toulouse, France. Professor Rosling received his MD and graduation in nephrology at Toulouse University Medical School in year 1988. In 1989, he was graduated in immunology in Aix-Marseille University Medical School. In 1988, he received a fellowship in transplantation from Heidelberg in Germany. In 1989, he received another fellowship in transplantation from Bristol in the United Kingdom. In the period between 1990 to 1994, he worked as assistant physician in clinical hematology and assistant physician in nephrology, dialysis, and transplantation. In the period between 1994 to 1998, he worked as consultant in multi-organ transplant service, and in 1999 he offered the professorship of nephrology, and in year 2000 he received the PhD from Toulouse University. The main fields of clinical and basic research include viral infections in dialysis and organ transplant recipients, anemia after kidney and liver transplantation, and the pharmacodynamic effects of immunosuppressants. Professor Rostin is a member of numerous scientific organizations and authored and co-authored 40 articles and published more than 200 papers. Professor Rostin will give us a lecture about the French donation and transplantation model. Professor Rostin, welcome to Mansoura Urology and Nephrology Center.
Means that locally we can't handle with the organs as we would like. So we can be a donor in France. So we've got two sets of donors, we've got the deceased donors and the living donors. So with regards to the deceased donors, so we mainly have brain dead donors. So roughly we have about 1,500 brain dead donors per year in France. So but this number is very stable. It's stable because we have very few trauma on the road, but we have a lot of cerebrovascular accidents in all patients, and so therefore the quality of the organ is not that good for patients on the suitable donation. We also have donors after cardiac death, means that when a patient has myocardial infarction and when it's not resuscitated, well, we can retrieve the organs, it's permitted. And now we've got the mast-cell-free criteria donors, means that when for a patient there is no medical hope, and when the physicians will suddenly decide to stop all the treatments, that is to say, the patient will die within a few minutes or hours or days. In these conditions, we can now retrieve the organs, as is the case already in UK or Germany or Netherlands. And finally, for deceased donation, this is the Christian consent. That is to say, we've got a national registry of refusal, and so if I decide to refuse to donate after my death, I have to register to this national registry, but very few people do register actually. So it means that even the law is with us. We always ask to the family members whether they agree or not that their beloved donates. So it means that overall we've got a refusal rate of about 36%. So it's quite big. And so by law we are forced to collect family's opinion, even though the law states that it's not necessary. So it's great. What about living donors? So in France, living donation is restricted to kidney donation. It was before that it was possible to donate a liver, or half of a liver, or half of a lung for kidney, for lung transplantation. But nowadays it's not permitted. So it's only restricted to kidney donation. The law is very liberal. It means that any friend, provided that you can demonstrate that your friendship is longer than 2 years, so any friend can donate. So first of all, we make a medical workup, and this is done by the transplant nephrologist, and we perform normally my center immune clearance, but this could be a different state of my clearance. And then thereafter, after this medical workup, the surgeon will decide whether it's possible or not with regards to the number of arteries, for example. And he will decide whether it will be laparoscopic or robotic surgery. And robotic surgery in my center is dedicated for obese donors, for obese recipients, and for female patients. And so afterwards, when all the medical and surgical work have been done, potential donor is audited by an ethical committee, and this is mandatory even though the donor is the husband or wife or mother, and so forth. And so this ethical committee can say no. And so this ethical committee convenes every month, and so they audit roughly around 6 potential donors. It means the donors have to queue up. So it takes time. The process of living donation in France takes time, at least 4 months. And afterwards, after this ethical committee has been passed, so if the answer is yes, the last word is given by the judge, and so by law, every potential donor has to show up before the judge, and the judge can say no. Normally it says yes. And so when it's done, you can proceed to donation. Okay, and in France, by law, also all the workup, the donation, the hospital stays are fully covered by law, by the hospital. And so it's very important because if you are living in France, or if your donor is living in the US, or if your donor is living in Egypt, they can come to France, they can donate, and all their expenses are covered by our hospital. And so it's great. So how many transplant centers do we have in France for kidney transplant centers? So in France we perform 3,000 kidneys a year, 3,000. So there are 34 kidney transplant centers, and of these there are 3 pediatric centers, 2 in Paris and 1 in Toulouse. And no, 1 in Paris, 1 in Toulouse, and 1 in Lyon. There are 22 liver transplant centers, and of these there are only 2 pediatric centers. There are 16 heart centers, 12 lung centers, 9 pancreas centers. In my hospital, we perform any kind of transplantations. And by law, all of these transplant centers are public centers, and by law, all are affiliated to University Hospital. If you are not affiliated to University Hospital, you can't open a transplant center even though you are okay, so if we come back to the donors, for the deceased donors, there are more than 200 hospitals that are authorized to identify and to manage such donors. It's very important because, as I showed you, there are only 34 kidney transplant centers, but more than 200 hospitals, this is the local, secondary, tertiary hospitals, are authorized. I mean, they have to apply to identify and manage such donors. Thereafter, when the donor is identified, they are either managed locally or they are transferred to a university hospital. And for living kidney donors, by definition, by law, only the university kidney transplant centers can look after living kidney donors. Okay, and at the moment, with regards to living donation, 80% is performed by laparoscopic surgery and 20% by robotic surgery. As you know, robotic surgery is very costly, so that's the issue. So how is working the kidney allocation system with regards to disease donors? Honestly, for the living donors, you can do whatever you want. But for the disease donors, it's complicated. So till now, but we change next year. Till now, 1 kidney is transplanted locally. It means that if yesterday there was a deceased donor in Toulouse University Hospital, we can keep locally 1 kidney, but that kidney is allocated to one of my patients by the national database, so that I don't choose my recipient. It means that the potential recipients are decided by the computer system. Okay? So I have to take the first one, and if I decline, I have to justify, otherwise I would be in trouble. And the allocation system is based on info. The local allocation system is based on age matching, time of waiting list, and age matching. So, 1 kidney is kept locally, but next year we will be changing, it will be no kidney locally. So. And 1 kidney is for the whole community, that is to say, by definition, 1 kidney is shipped. So, first, the computer system will look after kidney pancreas recipients, because we perform not enough kidney pancreas transplants in France. You know, we need very good donors, younger than 45, with a BMI lower than 25, something like that. So a lot of issues, but it's very difficult to have very good kidney pancreas donors. So computer system will look after the kidney pancreas recipient. If there is no such recipient in France, the computer will go to highly sensitized recipients. Because these patients are very complicated to transplant. They are almost, some of them, not transplantable with regards to their donor-specific THLA they have. And so the computer will look for the best HLA matched patient in France, and very often there are many patients. And so therefore you will take a patient who's waiting for a longer time. And there is also a program which is called Permitted Antigen. It's almost the same that runs in Eurotransplant. It means that the computer allows to look for potential donor for which there is no specific DSA. This is the visual cross match. And so therefore, if there is no potential TSA against that donor, but even though there is no X-ray matching, we don't care. And so the computer will allocate the kidney to that recipient with fully matched but with no TSA, because the recipient is highly sensitized. I don't want to be too confused. And thereafter, if there is no such recipient, the computer will go down to the best matched sensitized recipient, and at the end of the day, to the best matched non-sensitized patient. Okay? And so, the national agency will propose us a kidney for that recipient, potential recipient, and we can decline if the donor is 90 or a recipient with 65, we can decline. I'm not joking because we have a lot of old deceased donors. Okay, so what is preemptive kidney transplantation? It's very complicated. I mean, in the setting of deceased kidney donation. So in France, we have roughly 38,000 chronic dialysis patients. It's certainly less than in Egypt. And of these, there are only 10% or less who are PE. And of these 38,000, the mean age of these patients on chronic dialysis in France was 75 years old, the mean age. Okay? So a lot of them are not transplantable. So this is the reason why we only have 12,000 dialysis patients who are actually on the kidney transplant waiting list, and the government estimates that at least 18,000 should be placed on the kidney waiting list altogether. And so why there is this discrepancy? Because in France there are some private dialysis centers, some public ones, and obviously there is no reason for a private dialysis center to refer the patients to the hospital to put them on the kidney waiting list. So it's a big issue. So at the end of the day, we should end up with 80,000 dialysis patients on the kidney waiting list. But we perform only 3,000 kidneys per year, so you see there is a big gap. And so that's the reason why we try to, and of these, 3,000, there are only 500 who are from living donors, so we have a big gap to fill in. This is the reason why we try to develop living kidney transplantation in France. So we can list patients who are not on dialysis for preemptive kidney transplantation, but and so you see the figures. 1/3 of the patients who are waiting for a kidney transplant in France are not yet on dialysis. 1/3. But the computer system makes the things very hard for them. That is to say, you've got additional points if you're already on dialysis. So it's very difficult if you're not on dialysis to get a deceased kidney transplant. So they have to wait. So this is the mean age of donors in France, of deceased donors. So you see, in 2009, the mean age was roughly 47, and now it's 51. It's only the mean age. The median is almost the same, but half of the donors are older than 55, and we can have donors up to the age of 90, and we have an all-for-all program in France. And you see the mean, the yearly number of deceased donors, 1,500, 500, up to 1,700, but it's not enough. So this is this is for Toulouse. So you see the numbers are different for sure. So this is the number of yearly deceased donors. It's around 60. This year will be almost 80. So we are lucky this year. And the mean age of the donors is 54. So it's average and comparable to the French donors. So with regards to kidney transplantation, a few figures. So this is the total yearly number of kidney transplants in France. So 2009, less than 3,000. Right now, 3,200. And we perform, you see, only 514 living kidney transplants per year. It's nothing. I mean, it's nothing. It should be at least 50% if we want to improve the rate of kidney transplantations. So we have to convince our physicians first, because they are very good, that the living kidney donation is a good option, and thereafter we have to convince our residents. So this is the yearly number of living kidney transplantation in France. And in my center, we perform 65 living kidney transplantation per year. 65, that is to say, more than 10% of the national numbers. So we've got an all-for-all program for deceased donors. So you see, for the year 2013, the number of deceased donors who were older than 60, older than 70, or older than 80. So it's not that bad. It's 446 in 2013. It's increasing, and all these donors, all the kidneys from these donors are allocated by the computer system to all the recipients. All means older than 60 years of age, and so there is the all-for-all program. Okay, and it's a single kidney transplant, and sometimes it can be a dual kidney transplant. But we don't perform dual kidney transplant myself. So this is the yearly number of kidney transplantation in Toulouse. So 2013 it was 175, 2014 it was 197, and this year I hope it will be 200. And this is the number of living kidney donors. So it was 45 in 2013, 65 in 2013. It was 65 in 2014, and this year it will be also around 65. Okay. And so in France, it was forbidden to have an ABO, compatible kidney transplant program, till 2011. In 2011, the law was revised, and since 2011 it's possible to perform ABO, compatible kidney transplantation. And so this is the number in Toulouse of ABO compatible kidney transplants, 14 in 2014, and this year it will be 18. So I can skip that. So we have in France a program which is called permitted antigen. It means that for highly sensitized patients in whom the likelihood of having a disease donor is very, very low, and so there is a computer program to ascertain that that patient won't be able to find a suitable disease donor within 5 years, let's say. And so in France, there are roughly 500 patients who won't be transplanted so far because there are too sensitized against HLA antigens. And so for these patients, there is a program that it means that the computer is not looking for HLA matching, we don't care. It's only looking for potential disease donor for which or against which the patient has no antibodies. And so therefore, if the donor is A2, and if the recipient has no anti-A2 antibodies, even though, so the computer would say, okay, that donor maybe is suitable and blah, blah. And so it works. It works in a way that, you see, on a yearly basis, this permitted antigen program allows to transplant between 150 to 315 patients who otherwise won't be transplanted, and the graft survival at 1 year for these highly sensitized patients is 90% 1 year and 83 at 3 years, so it's not that bad because otherwise they would have been transplanted. So this is a very nice program with good results and allowing to transplant non-transplantable patients because they are too sensitized. So this is the yearly numbers of ABO transplantation in France. You see very few numbers, and so we started in 2011, and now it's increasing sharply. So we discussed about kidney transplantation, what about liver, heart, pancreas, and lung transplant programs in France. So with regards to liver transplantation, it's only deceased donors, as I said earlier on, and you see we transplant in France roughly 1,200 livers per year, and the indications are mainly Hep B, Hep C cirrhosis, hepatocarcinoma, and alcoholic cirrhosis. With regards to heart transplantation, you see we transplant roughly about 400 patients per year. With regards to lung transplantation, it's about 300. And with regards to pancreas, combined pancreas and kidney transplantation, it's less than 100. It's too few. We would need at least 200 cases per year, and we perform only 100, so it's very bad. What are we in Toulouse? So in Toulouse, we perform about 40 livers a year. This year, this will be more than 50. We perform about 15 heart a year. This year, this will be 30, so we increase very sharply. We perform about 20 lungs per year and 10 to 15 pancreas kidneys per year. Sorry. So he's in charge of the kidney transplant residents. So in most of the cases, in France, it's the nephrologist teams, and in some cases, we see the urologist team. We don't have this integrated system that you have here. And so how we organized in my center. So we are the single organ transplant center in France. That is to say, in the same facilities, we're looking after the heart, the liver, the pancreas, and the kidney transplant recipients, except the lung recipients. The lung recipients is looked after by a different team, lung team. So all these organ transplant recipients are coming in our units as part of the post-operative period, because we've got an ICU of 10 beds, we've ventilated patients, and a post-ICU facility of 18 beds. Except for the heart recipients who are coming to a department by post-op day 3 to 5 after the immediate post-op period. So this is the concept of transplant medicine, and it's just as it was in Pittsburgh. So immunosuppression as well as every complication is managed by the transplant team. It means that it's forbidden for one of our organ transplant recipients with any complication to go to another facility but our facility. So it means it's very time demanding, it's a huge amount of work, that every transplant patient's heart, liver, pancreas or kidney who has any kind of complication is coming back, of serious complications, is coming back to our units. And we have many consultants, obviously, on a daily basis. Urologists, pathologists, liver surgeons, cardiac surgeons, microbiologists, So, how do we manage kidney transplant candidates? So we are the largest area in France. So the area is about 50,000 square kilometers, larger than Belgium, but we are only less than 3 million inhabitants, so it's a very small area. It's a big area, but not well populated. So we have two big dialysis centers in the area, and so the dialysis centers refer the patient to a transplant nephrologist in order to know whether the patient can be placed in the kidney transplant units. And so if we think that it's possible, thereafter we refer these patients to our transplant urologist and the attending anesthesiologist. And we all decide together, the anesthesiologist, the kidney transplant surgeon, and the kidney transplant nephrologist, whether the patient is or is not suitable for kidney transplantation. And so, if a patient is suitable for kidney transplantation, he has by law to be listed in the kidney waiting list, even though it's a living kidney transplantation. And in my center, we force a patient to enter a program of therapeutic education with regards to the transplantation issues. So this is a pre-kidney transplant educational program. And so we will take about 10 patients at the same time for a one-day meeting. And so we explain then the issues with deceased donors versus living kidney transplantation. It's very important because if we want to increase the number of living donation, we need to have such programs whereby living donor comes and testifies and says, okay, I donated because blah, 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 blah. It's very important. And we also explain to patients who are waiting for a deceased donor, the ECD program, the old follow program, because obviously when you are at the age of 70, instead of that your wife or your husband donate your kidney, instead of having an ECD donor age 90, for example. And as soon as a patient has a suitable living kidney donor, is still placed by definition on the kidney waiting list, but it's put on the board. And so therefore, the computer system won't be available to allocate him a deceased kidney. It's very important because obviously we have to spare the kidneys, and so if there is a potential donor, a living potential donor instead of to get a living donor instead of a deceased donor. So so we've got a very nice urologist, Dr. Salusto, and this is the only one to perform a living kidney transplant. So we only perform, you see, a small number of living kidney transplants, so it's very important. Otherwise, there is a big team of urologists. We have a dedicated urologist that is in charge of laparoscopic surgery, and so we've got a big laparoscopic surgery program right now with regards to kidney donation and kidney transplantation in the living setting. Conversely, there are 10 urologists who are treating the deceased donors and who are performing the deceased donor kidney transplants. And in the event that the recipient requires a vascular bypass at the same time of the surgery or before surgery, we've got a dedicated vascular surgeon. So with regards to the postoperative period, so the patients are, as I said, they are hospitalized in our ICU or post-ICU beds, and on average they stay 6 to 7 days. So almost all of them are discharged at home. Some of them in the hospital hotel, and some of them to their local nephrologists if they still are on dialysis because of delayed graft function, for example, in the setting of deceased kidney donors. And we see the patients in the outpatient clinic at post-op days 10, 15, 30, 45, 60, and 90. And in between, they are looking after by their local nephrologists, we're looking at them. But the local nephrologists can't change immunosuppression, so we are the only one to be able to change immunosuppression. And as of post-op day 90, we see the patients on every 2 months, especially for assessing CMV viremia, BK viremia. So this is for the first year, and after the first year, we see them only twice a year. And in between, we are looking after by the local nephrologist. But as I said, the local nephrologist is not able to modify immunosuppression. You can adjust the dosage for sure, but you can't change the molecules. So, how do we follow up our patients? We don't have a protocol kidney transplant biopsy program because it's very interesting to perform protocol kidney transplant biopsies. However, it's very time demanding first. Secondly, very often we don't adjust immunosuppression accordingly. And so we only reserve surveillance biopsies to those patients who are AV compatible and or HLA compatible transplants. We assess by Luminex DSA at month 3 post-transplant, month 12, and then on a yearly basis. So we used to use, or still now, CMV prophylaxis with valganciclovir for the first 3 months for recipients who are CMV seropositive, or for the first 6 months for those who are donor positive recipient negative. But we will change next January, I will tell you later on, because it's very costly, and we will replace the valganciclovir by everolimus instead. So it will be as efficient and less costly. So we monitor BK viremia and viruria on days 30, 45, 60, 90, then every 2 months till month 12. It's very important because as soon as BK viruria is positive or looks controlled, or as soon as BK viremia is positive, we modify immunosuppression with stop MPA replaced by everolimus with CNI, and at the end of the day, we use no kidneys of BK viremia. We prophylax BCC for 6 months. And the GG stand is withdrawn on post-op day 45. It's a bit long for sure, but it fits with our follow-up. So, what was our activity in 2014? Sorry, I made a mistake. It was, no, 2015, something said 2015, but well, the figures are not accurate because there is still a few weeks. So, we will have had around 17 deceased donors, and of these, 2/3 are older than 60, and we have a lot of donors this year older than 80. Men or young women. We will have around, I hope, 200 kidney transplants this year, 197 last year. I hope to go beyond the 200. And of these, there are only 65 who are from the living donors. We will have around 15 kidney transplants, 10 Asian kidney transplants. And of these, around 1/3 received continual hemodynamics in addition to cyclosporine or TAP. We would have this year around 15 combined pancreas kidneys, 15 deceased liver transplants, and about 30 heart transplants, and 20 lung transplants, and unfinished.
Thank you very much, Professor Osman, for the illustrated lecture and then the lecture for comments and discussion.
So we got